Hi guys, thanks for joining. This is Essence of Medicine. Today we're going to be talking to a young surgeon about what is OLIF and the path for becoming a surgeon in the US. I'm Amanda Armagas.
And I'm Dr. Abbasi.
I'm Mohammed Numan Bashir.
Okay, well, now we just received the good news. Let's start with that.
Yeah.
What's the good news?
Well, the good news is by the grace of Almighty, I aced my boards. And actually,
Which boards? Because there are lots of different boards.
Oh yeah. So it's the United States Medical Licensing Examination. Actually, the result just came a couple of minutes back while we were about to start the podcast. So it's sort of
very fresh,
pretty historical, and you see, it will be a memory for me for the rest of my life.
Yeah, excellent. Well, now let's talk about what that board is. It's the USMLE, correct?
Yep.
Tell us, what is USMLE?
So it's basically United States Medical Licensing Examination. It's sort of like board certification and exam. So once you complete med school or during your med school, you have to appear for these boards. These are 8-hour, 9-hour, and 16-hour long exams.
Yes.
So
how many of them are there? USMLE.
So there are 3.
Okay.
So the first one is 8-hour long. You get 280 questions.
What is the content of the USMLE one? What are the questions in?
That's a great question, sir. So the USMLE Step 1 exam is often regarded as the world's most toughest exam. I don't believe in it, but this is what the people say, the med students say.
Yeah.
Just because they ask you they can ask you anything from the basic sciences stuff.
Yes.
So right from biology, biochemistry, anatomy, physiology, pathology, pharmacology, they can touch anything, right?
Yeah.
And then they go into genes and you see the receptors and stuff like that. So yeah, it's pretty tough. So you have 280 questions and you are graded from 0 to 300. So you are scored from 300, but now it has transitioned to pass fail. But initially people thought that it would become easy, but the recent statistics show that it has even become more difficult for the people to pass now.
Okay. Yeah. So let's start with that. First you go in United States, you go to first you go to undergrad in United States. After that, you can be admitted to med school.
Yes.
Outside of the United States, most of the countries in the world, you start the med school from the beginning and you had all your pre-med integrated in the med school itself. Like in Germany, med school is about 6 or 7 years. The first 2 years is the basic science of what we would call pre-med here. The last 4 years is equivalent to the med school here. But in the United States, these are separated.
Yes.
How is it in Pakistan?
In Pakistan, India, Bangladesh, and Southeast Asia, basically the med school starts after 12th grade.
So it's like Germany.
Yeah, absolutely like Germany, England, right? So it's kind of different in United States and Canada. I mean, the North America, it's kind of different. But in the rest of the world, how it is right after completing the matriculation, you enter a higher secondary school, which is sometimes called a college. And whatever the US students learn in their 4 years of undergrad, those students learn in their 2 years of high school. So basically, once you graduate from a 4-year bachelor program in the US, that's actually equivalent to the guy in India or Pakistan who has completed grade 12, the high school.
But still, the med school at least in Germany, is longer than here, meaning that the med school in Germany is actually 6 or 7 years, whereas here is 4 years. How many years is the med school in Pakistan and India?
So in Pakistan, India, Afghanistan, it's and China, even Japan as well, it is of 5 years. 5 years of med school right after grade 12. So you sit for an MCAT examination, medical college admission test examination. It is conducted by the state governments of the respective states. And you have to perform well in that MCAT examination. So this is how actually the merit is calculated in Pakistan. So they take 50% of the scores of your high school, like the 12th grade, right? 10% of the scores of your matriculation. So 50 plus 10, 60%. And the remaining 40% is from the entrance test, like the MCAT
entrance
exam.
Test. Got it.
So now this 100% aggregate is calculated. So wherever you land in the percentile rank, according to that you are allocated a particular government college. And the best thing is the government, the federal government, pays every penny of the med school for you.
Yeah, it is like in Germany, government pay for that. Now, once you do in Germany, you do German exams. In Pakistan, you do Pakistani exam, and in other countries their exam. But if you want to practice in the United States, you have to practically pass certain exams that in United they are called USMLE, United States Medical Licensing Examination. And they used to be there used to be many different, but now there is USMLE 1, which is that so-called basic science, as you described. And then there is a USMLE 2 that is called the clinical science. And then it used to be additional to that clinical skill test, which I believe is now removed. But then after that, there is a USMLE 3 as well. Now, in the United States, most of the med schoolers, they take the USMLE 1 and 2 during their med school. But USMLE 3 is usually taken during after the med school. Yeah, after the med school in the first few years of their residency. Now, and they are truly hard exams and so on. And they used to be, they have numbers to them that, if you didn't have certain numbers, you couldn't apply to any certain schools or certain residency programs.
So you could pass and get a low score, and then even though you pass, you still can't apply.
This is the trick. Let's suppose you pass, you get a low score. Basically, you are in no man's land.
Okay.
You pass and you get above 230. Let's suppose. So you can actually apply to medical specialties like family medicine, internal medicine, psychiatry. Like, you pass and you score 240, then you still are eligible for medicine, but you can now think of surgery, right? But still it's very competitive. You pass and now you score 245 or plus. Then you can think that you are a candidate for surgical sciences. You pass and you score 250 or plus, then you can actually work. You should actually start working on your CV, research, extracurricular, letter of recommendations to actually apply for surgical specialty.
For more competitive.
So 250 or plus.
So what did you score?
It's kind of good,
It's a good one. You're smiling. It's a good one. So you have USMLE 1, USMLE 2, and then within a year or two after you start the residency, you do a USMLE 3. There used to be so-called your clinical skill assessment, which is now removed. And then obviously there is for foreign graduate, there is a so-called language test, which is, it used to be specific to this, but now they have replaced it with so-called TOEFL.
Before it was TOEFL, but now they have replaced it with another English language exam. It's called the OET.
Okay.
So post-COVID era, they have actually removed the clinical skills, as Sir just rightly said.
Because clinical skill, you would go literally examine somebody who plays like a patient, but obviously they don't want you to have too much content.
So let me just tell you the time of the test. So the step 1 exam, which is, I just said, it's sometimes termed as the world's toughest exam. And I certainly believe it is, because while I was preparing for it, it took me nearly 7 months actually of constant studying. Because there is so much basic sciences stuff, although much of it is not used in our practical life, but still you must know basic stuff. So it's an 8-hour long exam. And the USMLE step 2, as Sir said, it is like clinical knowledge exam. They just give you a real patient scenarios, like a page long scenario. You see, like the Suri software that we use. So you see every patient has all this presenting complaint, history of present illness, labs. So that actually comes in real question, and they give you 5, 6, 7 options, and you have to select one. And in 90% of the questions, you actually get stuck between 2 and 3 options. So it is a 9-hour long exam, and the third USMLE step 3 is like 16-hour long exam. It is 2 consecutive days.
And the foreign graduate are disadvantaged because they give you half a page, sometimes a full page question with answers that you have to read and answer it within 45 seconds?
Oh, now, sir, it's 45 seconds to 1 minute you have. 60 seconds. Yes.
So in 1 minute, you have to read it all and have the answer ready.
Oh, and it's not in your native language.
And it's not in your native language. So it is much harder for foreigner to get the high score
Yep.
because it is,
Not in the
more or less a language test as
Yeah.
well.
Yes, sir. Actually, that's why it takes a long time because you see, you have all that clinical vignette, and you just have to scan the most important,
Yeah.
pertinent, imperative information because the exam the one who makes the exam, exam setter, he tries to puzzle you.
Of course.
So,
Yeah,
for
yeah.
example, the other day, Jamie was asking what sort of questions are asked. So I told him, like, there is a patient who has cogwheel rigidity, lead pipe rigidity, he has stooped posture, like hypokinesia, all symptoms of Parkinson's disease. And in the last line, he'll say, and last week he also experienced hallucinations. So obviously the diagnosis will change from Parkinson's disease to Lewy body dementia. So this is how, like, they try to puzzle you.
Yeah, leave it till the very end.
Yep.
Yeah, yeah.
Yep.
So it is now, and now obviously you have to have a good knowledge base to answer the question.
Yep. Yep.
But as well, even if you have all the knowledge, if you miss one piece,
Yeah.
then you're
Yeah.
going the wrong direction.
Yeah.
So a little bit of a tricky exam as well.
But if you pass your USMLEs, then you're able to also practice in other countries. I know that in Australia, if you pass your USMLE,
Actually,
then you
you get a certification in any country in the world, but still to become a consultant or like you choose a particular field, you need to go through a residency. So like residency application is not just the USMLEs. It's basically a whole application comprising scores are one part of it. The remaining part is like the research, the volunteer work, the clinical rotations that you did, the letter of recommendations that you got. So it's basically a culmination of all these things. Yeah, but scores are very important. It's the first step to actually enter the arena.
Yep.
So
now, once you pass all of that, you get a certificate as a foreigner. It's called ECFMG.
Yep.
Education, that's for ECFMG stands for Educational Committee for Foreign Medical Graduate. That means that they accept your training and your path to get there as equivalent to a US trained person. But again, that just enables you to enter a residency. So you're just starting a new path. See, in medicine, you start the K-12, and once you pass K-12, you're so happy, K-12. But then you start going to college, and then once you get to a college and pass the college, you say, hey, I passed the college. Start over again. Now you go to med school. You start the med school. Hey, I'm a med schooler, finally. Then at the end, I have to pass the exam. And then you pass the exam, you have to start the residency. Then you pass the residency. Oh my God. Then you have to do a fellowship. Find a place for a fellowship. Start all over again.
Sometimes you have to do two.
Sometimes people do more than one. But once you pass the fellowship, you say, wow, I finally made it. Now you have to go out and gather experience and become a good surgeon. So it is a never-ending story.
Your hair turns white and gray by that time,
Yes, as our mind. So it is a continuous, challenge and a word that you have to learn. But what I tell everybody is that the journey as well is the goal. The journey is that I tell to my kids that the time will pass if you learn or you don't learn. The time will pass. Meaning that you as well can sit in front of the TV and on a couch and watch Simpson all day long.
Yes.
And then time will pass as well. That it certainly requires lots of sacrifice to get there. So congratulations on passing one more step in that journey.
Thank you, sir.
Where does board eligibility or board certification come in?
Now,
ECFMG, sir said it already.
Yeah, well, there are obviously medical licensing board, but then they are on top of that. Once you are when you go through a residency in a discipline, then each board, like neurosurgery, has a neurosurgical board, meaning that they decide what do you have to learn to be a neurosurgeon. They put a program together. Now in US it's really good. In Germany they tried and it was miserable. When I was a resident in Germany, it wasn't really a board and so on. It just was a hatch patch of you have to do certain years here, you have to do this surgery and so on. But it wasn't anything that you say, I start this day, I do this year, this next year, and then I will be done. It's very good in the United States, actually. You go from year to year, you learn, you go through certain steps. At the end, you pass the exam, neurosurgery at least. In most of the other disciplines, the same. Then you're still not done. You're board eligible.
Yeah.
You're not board certified. Like, I went like 3 years in neurosurgery in Germany. Then I did 2.5, 3 years residency, and I'm doing research in the United States. But then I started all over. I did another 7 years residency in the United States. And at the end of that, I got a certificate that I passed my residency with the according, exam and so on. Now I was board eligible.
Wow.
Then for 2.5 years, I gathered my cases, submitted to the neurosurgical board, and then I sat through another exam. Then I was board certified.
Wow.
Now, having said that, I started obviously, I finished my K-12 at 17. By the time I finished my board certification, I was 43. So 26 years from high school to get board.
So I have a question. So so for you to become a certified neurosurgeon, it took like 23 years.
It took longer for me because I did research, I did PhD, I did half residency in Germany. But generally, I would say it is 12 years of high school. Then you generally in the United States about 4 years of undergrad.
Yes.
So add please together 12 and 4, 16.
The number is 16 right now, or 16 plus 12 plus 14?
Well, let's say K-12, we put it to the side. Let's start after the K-12.
Yeah.
So let's say 4 years of undergrad.
Yep.
Then 4 years of med school. Best case scenario.
Yeah.
Okay. You're already with 8.
8 years.
Then you do 1 year of internship. That makes 9.
9.
Then most of the neurosurgery, they used to be 6 years. Now they are 7 years. So 9 and 7 made 16.
Yep.
Then most of people get 1 year of fellowship. 17 years after the high school. 17 years. And that's what it takes for them to let you touch somebody's brain.
And for foreign medical graduates, like it's even more. Because you see, they have to do at least 1 or 2 years of research internship or work with a neurosurgeon, like on his research projects or like what. And then even like it's very difficult because I don't know, like there is this sort of a bias, but as people say, but they say like international medical. So there was this guy in my med school. So he was taking our class. He was, I guess, medicine guy, I don't know. So he just said in an open room, better prepare to win a gold medal in Olympics than to apply for neurosurgery application and residency spot in the US. I don't know how true he was, but this is what he said back in the time.
Now, what we need to emphasize as well, that after that, what did you say, 17 years or 16 years?
17.
Yeah.
You're board eligible. You're not board certified. 3 more years. Now, minimum 3 more years, because I did my board certification within 2.5 years, and that's the fastest you can do it. In average, that's 5 years. In average.
Can you? I might be wrong. I feel like some of our friends, or maybe one of our friends, is a surgeon and is board eligible but not board certified, but still practicing pretty much.
Oh no, you can practice as a board eligible. You can practice, but you need to gather your cases. You have to present them. You have to sit for another exam to be board certified. And then every 10 years, you have to redo your board certification and so on.
When do you have to do yours?
Well, I just, last year, I did my second cycle, meaning that I was past it for 10 years. And then now I'm sitting for this is my second cycle, meaning that second 10 years. But every year I have to do additional training and so on.
How many CMEs do you have to get per year?
No, that CMEs, is different. You need to have CMEs per hospital bylaws. You need to have CMEs for state licensing, and then you have to have CMEs for your continuation of your medical board certification and so on. So that is from state to state different, but usually it's not that much. In some states it's 25 CMEs, in some states it's 50 CMEs.
And CME stands for continuing medical education.
And that is usually about 1 hour education is considered one CME, usually.
Yes.
But that's not much, 25 hours a year is not really.
Month, 2 hours a month.
Yeah, about 2 to 4 hours a month.
That's not much.
Yeah,
that's not bad.
But then once you have passed through all of that, you get a state license.
State license.
Then you get a hospital privileges, which is different. Each state is different. Each hospital is a separate thing. Then you get your credential with the insurance companies. Each of them is different.
Yeah.
And then
you get blackmailed by the attorneys. Right?
Blackmailed by attorneys?
Yeah.
Yes.
They sue you basically. So I've seen a lot of surgeons, sir. You might have come across a number of them. While they practice something which we term as defensive medicine. So now they have actually incorporated defensive medicine into the course of USMLE. So they ask the questions regarding defensive medicine in the actual exam.
So what is that?
So
explain that.
Yeah. So defensive medicine is a sort of a concocted concept in which a physician or a surgeon orders investigations that aren't actually
lots
required.
Of tests that is just to make sure that you don't come back and sue you.
Yeah, the attorney doesn't come and sue you. So,
but then you have me as a patient, I'm just thinking, because I actually went through a lot of medical tests recently. Then you have to pay for each individual.
Oh yes.
Yeah.
Oh yes.
You. That's kind of a burden on the patient. I just
doctors don't pay for that.
No,
patients end up paying for that.
So if it's just in case, I had a colonoscopy recently, and my doctor's like, "Well, let's test for this and let's test for that." And I'm like, I don't want to test for all of these things just to be safe.
Yeah, let's put it that way. To a certain degree, certainly, we have to do the right thing. We have to do it in a certain thing, in certain order, with certain protocols and so on. But on the other side, the medical legal part of medicine in the United States is suffocating.
Mm-hmm. Yes, it's exhausting.
Yes,
it's exhaustive, not only for the doctors, but as well for the patient. But the mostly who benefits from that are the lawyers.
Yes, lawyers and insurance companies.
Well, and insurance companies, that is who benefit from them.
Like the defensive medicine is just to cite an example. So the tertiary care teaching hospitals, which are affiliated to my medical school back in Pakistan. So while I was doing 1 year of clinical internship there, you know what I saw? Every patient that walks in the medicine department, for example, the medicine emergency, the nurse used to fill the entire dexamethasone, injection 1 gram ceftriaxone, and injection Toradol. Toradol is like ketorolac, right?
Yeah, ketorolac. Toradol, which is a
painkiller. Yeah, it's a painkiller.
Pain medication.
The combination of all these 3 injections should straight away give to the patient. Up till now, no first contact has occurred between the patient or any attending doctor. So this was just because they were worried, if the patient dies, in that part of the world, there are actually many different problems. So the family is going to come and beat the doctor.
Beat?
In Pakistan?
Yeah, in India, Pakistan as well. So
really?
So let's suppose.
So there's some physical altercation there.
So I see a number of times. So let me just cite.
At least we are in the United States.
You're
safe regarding that.
So you see, there are numerous instances actually when the family brings an already dead patient to the emergency, and they just try to resuscitate the patient, give him oxygen, and all of a sudden the patient couldn't make it. What happened? I've seen it with my eyes right in front of me. So what the family does, they actually call the media, and these media goons, they just come in there with their mics and cameramans, and they said, look, this doctor, he was having his lunch and calling on phone and having a luxury time, and just because he didn't see the patient, he died. This is impossible, this can't happen in a tertiary care teaching hospital, which is affiliated to a medical university. Right? So they beat the doctor, and there are certain instances where the doctors actually landed in an emergency.
The doctor ended up on the emergency table room.
That
That's
sounds
true.
like
Well, no, we are
Pretty safe.
much safer here in the United States now, but we are safer here because we have probably because at certain point we went through all those phases that you know patients are unhappy. Like they obviously wouldn't let any media or journalist to ER here in the United States. There would be cameras everywhere and so on. So we have practically very well organized medical care delivery in the United States. Doesn't mean
very well organized.
Well,
you might have come across
compared to getting beaten up in India and Pakistan.
It's very organized. There's so many hoops.
Yeah.
I guess you guys have come across a recent incident in India where a doctor was in the hospital and look what happened. So this is the level of safety in our part of the world.
No,
so
but tell what happened because maybe not everybody knows.
So basically, she was on call. She was taking care of her patients, and the details have actually the case is sub judice. It is in the Supreme Court of India, but what details have come out are like she was sort of raped, right, by 20
severely,
men, right?
Yeah,
and
horrible.
And you see the irony is that rather than launching a first investigation report and calling the police, the hospital administration told her parents that she committed a suicide while she was on call.
They were trying to suppress the true event.
Yes.
That is even more egregious, and that's the most horrible thing that
then you lose all credibility at that point. Like it's then you can't say these guys did this, I don't know them or anything like that.
But
you're defending the guys.
But you see, that part as well happens sometimes, not to that point, but to certain point as well in the United States. That
really?
Not something like that. Okay. Not like that, but that when something bad happened, the hospital tried to suppress and find a scapegoat. And that part, we know much about that, but that's for another podcast.
Maybe in a while,
Maybe in a while. That podcast will come.
Yep. The other day, like I was listening to because I'm following this case because she was from our fraternity, right?
Oh,
and
wow.
This could be any one of us. So like I was listening to the remarks passed by the Honorable Chief Justice of the Supreme Court, and he said, how can we ascertain that she was on call, on duty, and she committed a suicide? And the post-mortem report showed that all the bones were broken. Just imagine the amount of pain and trauma that she underwent.
Who were these men?
Sir, you see the government.
There were some gangsters.
There were some. So the local government is still, I think, so trying to find them. And you see, the other day, all the doctors from the state, even in Pakistan, it's not just in India. In Pakistan, they came out on roads. They say, just provide us with dignity, safety, and security, and then we are gonna work, right? And you see, the state government resorted to violence upon those doctors who were protesting what happened with one of their colleagues.
So sad.
Well, but at least we know, we see the whole world knows about that.
Yes.
Now, the sad part and the good part is the same. This sort of things have been happening all along, but now everybody knows about that, and now we are not going to be able to keep public silent about that.
Yes.
So we are that I'm hoping that horrible tragedy will really start a chain of changes, not only in India or Pakistan, but all around the world.
Yes.
That we are accountable. We have rule of laws, and even in the United States, when bad things happen, there is a order, there is a path, there is. For a long time, bad people could do anything with impunity, but
now only some bad people.
Not only some bad people, but at the end of the day, the truth will come out.
Yes.
Okay. Well, that's a sad place, but I think we are moving overall in the right direction. So, what else do we want to talk about?
I wanted to get Dr. Bashir's opinion on the OLIF procedure.
Oh, yeah.
I want to give our people watching some background.
Guys, it's been one day I've been here in Minnesota. I've actually traveled 70-hour long flight, including the delays from Pakistan to Minneapolis. And I just want to say, this procedure, this phenomenal procedure, it's the future of spine surgery. Because what I've just seen, like a couple of hours back, I haven't seen up till now in 7 years of medical. I'm very junior most here, so 7 years of medical career or medical education that I have been through. So a patient just underwent a trans-cambial OLIF procedure, and Dr. Abbasi did trans-cambial OLIF along with his team, and I had this privilege to observe this procedure. Literally, there was not even a single drop of blood on the floor. Like the floor was clean, crystal clear, right? And so there is this physician assistant, her name is Alyssa. I just talked to her, I said, why isn't there any because back in my home country, the operation theater is filled with floor, you see, because they give long incisions and resort to open traditional approach. Yeah. So here the operation theater was clean, sterile, no blood. And you see, and very important thing that I'll never ever forget in my life. So when we were about to commence the second surgery, the patient who went OLIF, by that time he went home.
Yes.
So when we walked out of the operation theater, we said, where is the second? Where is the first patient?
So
he wasn't there.
Let's talk about the first surgery. The first surgery was a 2-level L4 to S1 trans-cambial OLLIF, or oblique lateral posterior lumbar interbody fusion. And we did that surgery in a surgery center.
Yes.
What that means is that this is a place that is not like a hospital, and it's a place that patient get the surgery and discharge same day. That is by itself is very unusual, because practically vast majority, 98-99% of the patients who do spinal fusion, they have to stay in the hospital for a few days.
Yes. Mm-hmm.
Now, as well, I think what's important here is to understand that what we did today is not specific to me. It's not just superior skill of Dr. Abbasi. It's the different procedure that doesn't cause lots of. You said usually in the United States we don't have much blood on the floor. Sometimes we do, but usually we try to avoid that by sucking all of it out.
Oh yeah.
No, see, that's the point. The blood does in a regular surgery.
Yes.
Even if the floor is clean, that blood comes out, and we suck big containers of blood of patient during the surgery. Like for a 2-level fusion, somewhere between 500 to 1,000 cc of blood loss is nothing unusual.
Nothing unusual, yes.
We lost 68 cc of blood.
Which is like less than this.
Yeah, it's actually
even less than this.
It's less than the water inside of this.
Yep.
But the idea here is that 68 was 68, because sometimes when I put my result in the LinkedIn, someone say, "Oh, how can you be so accurate?" So what do you think? How did you notice? How do we measure the blood loss? How do we know it's at 68 and we are not guessing?
Well, that's a very important point, because I think that there is a dried blood content and there is the liquid blood content, and how probably you just take out the difference of it.
So
I guess.
What we don't use suction, but we use sponges. We soak all the blood in sponges.
Yep.
And we measure the weight of the sponges when they are dry, and after the surgery when they are soaked with blood. The difference is the actual blood loss.
Yes.
So this is not estimated blood loss. This is the pretty accurate blood loss. What as well is important here, because why do we have little blood loss? So little, but like 1/10, 1/15 of the blood loss.
Yes, sir.
Because we don't cause so much damage and trauma to the tissue.
Yes.
And the little blood loss is just the consequence of little trauma to surrounding tissue, and little trauma or much, much less trauma to the surrounding tissue is what makes the patient to be able to be discharged from after 2-level fusion within 1.5 hours.
I just want to say, so while I was having an internship at the neurosurgery department back in my home country, so the attending actually gave a patient under my care, and my duty was to actually change her dressing. So what happened with this particular woman? So she underwent a open discectomy. So traditionally discectomy is and was done like via open approach. They give a long incision and midline.
And we are not talking fusion, discectomy.
Discectomy.
Yeah. Okay, got it.
So what happened was there were staples the side where the incision was given, and she had, as far as I had 3 months of rotation at neurosurgery, and for 1.5 months she was under my care, so she wasn't discharged. You know why?
Mhm.
Because post operatively she developed infection, surgical site infection. There was purulent fluid oozing out of that incision, and
Mhm.
every day early morning I used to go wipe out that purulent fluid from an incision and then just put some sterile bandage on it. And I used to do like 2 or 3 times every day, and I still remember the pain with which she used to cry. Oh my
Yeah,
gosh.
yeah. Now we are talking about infection. Let's talk about infection.
Yep.
What is in the United States, probably the numbers are different. What is the typical rate of infection after spine surgery in Pakistan? And I will tell you what is in the United States.
Well, actually,
What
it's a
percent?
lot. Sir, it is a lot because just on average, the patient actually stays like 2 weeks or 1 week at least. In my particular personal experience, I haven't seen anyone going like after the surgery, just couple of minutes after the surgery, you go back home. Like,
Now you see that. Now you saw that.
this was surreal, guys. This was so surreal. I just told the people in the operating room that this is seeming surreal, and they were laughing. They say we do it
Yeah.
every other day.
They're like,
So,
what?
Yep.
Now the rate of infection in the United States for the spinal surgeries is 3 to 5%. For spinal fusion,
Yep.
can be even higher in complex cases like multi-level fusion and so on. In some places, it can be 5 to 8%.
Yep.
Our risk of a spinal fusion infection after spinal fusion is 0.3%, meaning 115 to 120th of the open surgery. As a matter of fact, after 1,600 cases, we had only 3 infections,
Yes.
and none of them needed incision and drain. All
Yeah.
3 of them reacted
They
to
were
the
localized infections. Yeah.
very localized
Very
infection.
localized.
But that's important as well. Why? Because those 3 patients, one of them was a smoker, diabetes, high BMI.
Yeah.
The other one had some rheumatologic disease and lost like 30 pounds in 4 weeks.
Yep.
So something major was going on.
Yep.
And the third one, we had some good indication that there's some IV drug was involved in that case. So you see, those 3 infections,
Yep.
they were extraordinary circumstances, and I can just tell you that is very, very different than any other spine surgery that's out there.
Well, I've seen it for my eyes, so I can actually advocate for it because I've seen something with my own eyes.
Yeah.
So I just want to bring in one more thing. So like the perioperative fluoroscopy duration, that is pretty less. That's what I'm actually researching on one of my project with Dr. Dominic and Dr. Abbasi. So like the perioperative fluoroscopy duration is very less as compared to like other techniques. Like, would you like to add about something?
Yeah, well, you see, during this surgery, we use 2 C-arm.
Yep.
And we get the information from these 2 C-arm. We put in our mind, we put it together.
Yep.
And that is one of the advantage of these surgeries. Like many spine surgeons use these days robots, neuronavigation, and so on. Those are multi-million-dollar machines.
Yes.
Where here we need a handful of instruments and 2 C-arms, which enable us to perform this surgery in countries that they don't have $5 million spare for these machines and so on. As a matter of fact, we are going to go hopefully to India, maybe even in the future to Bangladesh and Pakistan, to be able to teach them to do this surgery, because again, they don't need to buy a $2 million robot and a navigation machine to do the surgery. But you get x-rays in 2 different directions. Now, some surgeons have consideration and concerns about how much radiation do you get when you do that. Now, and if you were using the C-arms from 1950s, 60s, 70s, that concern would be real. But with modern technology, the amount of the radiation you get is like 1/300th of the machine that was 40, 30, 50 years old. So, and that is what we are measuring right now. We are measuring how much radiation you get. And just to put it in perspective, in a 1-level fusion, we usually get 1 to 2 minutes of X-ray time.
Yep.
In a 2-level fusion, we get about 3 minutes to 3.5 minutes of X-ray time.
Yep.
Now, when you get a cardiac cath, you get like 30, 40 minutes of fluoro time or X-ray time. And when you get a cranial angiogram, you get like 20 to 25 minutes. So 1/5 of what you get for the cranial or cardiac cath and so on. So it is much, much less. But that study is still running. So we will publish that study, tell us how much radiation the surgeon gets from the for the patient, the impact is really minimal because patient doesn't get that exposure day in, day out, but surgeon does. So that is the idea. Like it seems that our surgeon that they perform the surgery still get the amount of radiation that is way, way below accepted standards.
But even then, surgeons like Dr. Kim, I think he wears special glasses,
Yes.
special gloves. You can still completely suit up.
Yeah. There are additional ways, but again, we are running that study. One of our studies that's going to be published hopefully soon is exactly about how much that radiation is.
One thing I thought was really interesting is Dr. Bashir mentioned that in Pakistan, they're not really doing minimally invasive spinal fusions.
Well, there are certain centers where they've actually started. So there is this gentleman, Dr. Soban Gondal. He's a very famous neurosurgeon in like the capital, and he'll definitely be the part of Inspired Spine Symposium next week, which we'll be having which we'll be having. So he has started minimally invasive surgery. So he does TLIF, DLIF. He started minimally invasive surgeries. But as far as the government sector is concerned, like because you see, majority of the population resorts to government sector because it's free. The government pays for all the healthcare costs. So 90% of the population goes to government hospitals, and in the government hospitals, traditional open surgeries are practiced. So there is no minimally invasive. So this gentleman, like he is my teacher as well. So he has started minimally invasive surgeries in one of the government hospitals, and he does in private as well. Okay. So yeah,
I think this is, as you mentioned, yes, in many of these countries, there is a private versus government, kind of healthcare. And generally, the government or public healthcare has much lower standard because resources are limited. But that's exactly why the OLIF is so important, because all of a sudden, now, like, you don't have to wait years to get your surgery. You don't have to do a surgery and keep the patient 2 weeks in the hospital. You don't have to bring them back for incision and drain of the infection. Now, I go once a month to Kansas and I do 12 to 14 surgeries in 2 days.
Wow.
And in one room, even. What that means is, now imagine if you can, the technology allows you to utilize the staff, the room, the hospital for 4 times more patient. So then you can reduce the impact that each of those patients has on the healthcare, reduce the cost. As a matter of fact, we published a paper about the economy of this. It makes the delivery of spinal fusion to the patient much, much cheaper because those patients don't have infection. You can do 5 of them a day instead of 2 or 1. You don't have to take them back for infection. And they don't stay in the hospital 5 to 10 days. They go home same day or next day.
And you can treat a wider range of patients too.
Absolutely,
so I just want, like Dr. Abbasi, to actually tell the Pakistani and Indian audience who is seeing this podcast, like trans-cambial OLLIF, like what type of spine pathologies can it treat? Like I know it can treat a lot, like the scoliosis, spondylolisthesis, but I just want like the expert opinion.
Yeah, see, the indication for OLIF is no different than indication for general spinal fusion. Now, there are some categories that we call instability and some categories that we call the degenerative changes. Now, obviously, instability is easy. Like you have mobile listhesis, you have broken bone, you have things that make the spine move the wrong way, hence it's instability. Then for degenerative changes is practically anything that causes spinal stenosis, claudication, or what we call pain, mostly pain, or neurological symptoms. And most of that comes from some tissue pushing on neural structures. Now, what can push on neural structure? Now, herniated disc, generally we just go trim it out. But if a disc repeatedly comes out and push on the nerves, every time you do surgery, you create scar. Eventually, you have to get rid of that disc. Like you patch the tire of your car once or twice, but if the tire is just keep busting on you, you have to replace it. Now, then we have so-called stenosis. Sometimes to remove the stenosis, we have to take so much tissue away that we cause what we call iatrogenic, meaning doctor-caused instability.
Medical, yep.
And then obviously, this is now a little controversial. Pain for axial pain, fusion for axial pain, because when you move, when the disc is gone, bone is grinding the bone, and the different tissue are damaged and cause significant axial, meaning back pain. And when all the other method of helping the patient fails, then surgery would become an option. Now, now individual pathologies like spondylolisthesis, stenosis, scoliosis, which one is suitable for OLIF is depending on how much experience do you have with that.
Yep.
We have created what we call soft transition, a path to get good and better and good and excellent at this trans-cambial OLIF. And depending on at what level you are, you can take on more complex pathologies. As well, there is, as Amanda was alluding to, there is a segment of society that is not a candidate for regular surgery, like elderly people with comorbidity, high BMI.
In the US, it's a huge segment.
So all the patients that we just treated, like not even a single one of them had BMI less than 35. All of them were above 35, above 40, and one was like, I guess, 42 or 45.
42, yeah.
So back in my country, like I wish. So I just want to bring one incident here. So a few months back, while there was a woman, her spinal surgery failed. She had something we term as failed spinal surgery syndrome, right?
Failed back syndrome.
Failed low back surgery syndrome. So like she was I think so 40 or 45 BMI, and the surgeon actually refused to offer her a surgery. He said her that at this BMI we usually do not operate, or if we operate, then the results will be detrimental. So first reduce your weight, and then we're gonna think of doing something with you. I just humbly asked this, agreed that surgeon, and said, like, what if you just do trans-cambial OLIF? Because I've actually, at that time I was studying all the research that has been published by the Inspired Spine. So he started bashing me. I don't know, out of nowhere he started and
What was he saying?
And he was saying, show me the papers. Then I sent probably there were just a few studies only by this particular hospital. Then the irony was, like, couple of his friends actually popped in, and the trio actually got on me, and they started,
welcome to my world.
So I said, you asked the opinion. So you see, just like this, so you post and ask the opinion.
Were the surgeon in Pakistan or here in the United States?
So couple of them were in Pakistan, and one was couple of them were in United States, at Colombia. I just don't want to name. And one of them was of Pakistani origin. Like, he also practices here.
Yeah.
So they started.
We know most of them.
I know. I was thinking, don't say the name.
I won't ever say the name. I won't ever. But sir knows them because they are in the service friend list, right? So they started bashing me, and I said, "You asked the opinion that what should be done with this patient." I said, either send this patient to this center, or just you better perform yourself trans-cambial OLIF procedure. They said, send us the studies. They said, who accepts this procedure anywhere in the world? Is this practiced anywhere in the world? Like, they started asking all those questions, and after a couple of days, I left the chat. I said,
yes,
okay.
good. Sometimes you learned it much faster than I did. You cannot teach old dogs new tricks. Most of them are not even that old either.
I wish they were today,
Yeah.
They would have seen for themselves. So you see, this is actually human nature. Since the inception of human beings on this planet, the biggest hurdle towards progress is not like we don't know how to innovate. To embrace innovation, this is the biggest hurdle, because we do not want to lose the comfort of our couch. We do not want to accept anything that is different than our regularly practiced stuff. Right? So here, if an innovation is practiced or innovation is done, so why not the world must embrace the innovation or appreciate it or constructively criticize it rather than just bashing someone who is just new to this arena field. I just
Yeah.
Yep.
Now, this is not new, as you said, this is not new to humanity.
We talk
Yep.
about it all the time.
Yep.
Yeah,
Yep.
we have a lot of, actually, Amanda and I, we have a lots of experience with that.
Yep.
And there is a practically spine is a big deal
Yep.
because there are more than 1.5 million of the spinal
Yep.
surgeries
We
are
all
done.
have one.
Well, we all have spine, and
Yeah.
we all eventually we all need one, some help in one way or another. So there are lots of financial interest involved in that, and change new things makes the old things less relevant.
That's true.
And people don't like to lose.
That's true.
Imagine if you're at the top of your career, like you're the best open spine surgeon in the world, and then someone's like, well, why don't you try doing it minimally invasively? Then you're going to feel maybe a little bit
Actually, you
knocked
see,
down.
Embarrassed?
Yeah, embarrassed.
But then you see that there we should have I thought that totally I get, but and that they don't want to go and learn new things as well, I get. But see, if a surgeon have 8% risk of infection, he shouldn't bash a surgery that has
Yes.
even a chance of,
Yes.
No.
let's say, 5% or 3%
Yes.
risk of infection.
I agree.
See, that would be completely contrary to
Yes.
ethic of a physician
Yes.
who is practically committed to provide the better care.
Totally.
You know, it's all the medical ethics that we have to adhere to. Otherwise, we should stop calling ourselves as healthcare professionals. So medical ethics come first. So let's suppose the question that you posed, that there is a gentleman is a like best spine surgeon. He does open surgeries
Mhm.
with very dexterity, right?
Mhm.
And all of a sudden he hears of minimally invasive stuff. So what's gonna happen with him? If he's great, he must be humble and he must learn that and actually embrace that innovation.
Mhm.
This is because all what we are doing is for the patients, not for ourselves. You see?
Definitely.
Mhm.
So whatever is best for the patients, we must choose that.
It's all about the
You,
patient.
you should see some of those comments they put on my they gave up on me, but
Really?
they used to put on my LinkedIn comment.
Yeah.
You see, so we have names for those people like Lordosis and
Well, we call them the LinkedIn warriors.
LinkedIn warriors. Yeah.
Oh, the ones who took out on me, they are actually in the sir's friend list and they actually communicate with sir.
Really?
And yes, at that time when they were doing this to me, I thought that I should send it to you or Dr.
You should have. You would
And I
have.
thought like they are his
should have a
colleagues and
blast.
it doesn't look nice.
It's okay.
Yeah.
Well, you
We
see,
can always invite them.
and we do constantly.
Yeah.
And then, so do you know sometimes what they say? Some of them, they say they don't have time.
Yeah.
They don't have time because their surgeries take 7 hours.
So we also experienced like I observed like SIJ trident, SIJ fusion. Like this is I just want to talk for the people from my country, India, Bangladesh. So like in our part of the world, if someone comes for sacroiliac joint pain, in 99.99% of the times, he or she'll be treated
For the
with a s-
spine.
with the same as the lumbar pain. They'll probably if you are so let's suppose a highly competent or ardent surgeon will perform Faber's test or what's it called, distraction test or stuff
Yeah,
like that.
Gansling test.
Yeah,
So let me
Gansling test.
translate that to what it means.
Yep.
Imagine you go to somebody to check your ears.
Hmm.
They
They
take
start
your
looking at my nose.
no,
Yep.
they take your tooth out. They pull out your tooth. That's what the translation
Yep.
of that is.
Yep.
That's
Yeah,
what it
okay.
means. Now let's talk about sacroiliac joint.
Yep.
Well, actually,
Imagine-
before we talk about it, I want to say that's not unique to Pakistan because we were in Louisville. We were at
Oh, this is only practiced here in the US or probably here at this
but
hospital.
Even here, people deny it. We were,
Really?
yeah, we were at a university, and the university people, like the students, were
Wow.
arguing with Dr. Abasi and saying,
That's-
"We don't believe in that."
No, they
The
said
residents.
this is interesting. In a university, they said we do not believe in sacroiliac joint. Well,
What?
I know.
as if as if that sacroiliac joint disease is a religious thing that okay, we believe in this but not in that. Whereas this is what do you mean? You don't believe in that. So this is fact. This is the research. This is the studies. You get 100 patients who have lower back pain. 23 of them will have actually sacroiliac joint problem, not spine problem.
Yep.
If you don't include that in your differential diagnosis, you're going to miss that. Now, imagine now you get 100 patient who had previous spinal fusion and now come to you because they have back pain. What do you guess what percentage of them will have a sacroiliac joint problem versus truly still spine problem?
Probably like 30% of them.
43%.
40. Okay.
This is studies and there are references for that. So the sacroiliac joint is the most neglected
Yes.
area of the spine.
Yep.
We have two names for sacroiliac joint, and that summarizes it all. The number one, I would say, cutesy name we have for sacroiliac joint is the so-called the chameleon joint.
Do you know what a chameleon?
Chameleon is a small little animal that can change the color and can.
Oh yeah.
Yeah. Not a lizard, but it can change the color. It can look like an environment because sacroiliac joint. Yeah, it can camouflage itself because sacroiliac joint can give you symptoms that are like pelvic floor, like hip, like spine, like facet, like neuropathy. Sacroiliac joint has so many different kind of presentation. That's why we call it chameleon joint. And we have another cutesy name for sacroiliac joint. We call it miracle joint. Miracle, like wonder joint. Because this patient go tens of years, they become suicidal because everybody says it's in your head. There's nothing wrong with you. Everybody look at their spine and they neglect the sacroiliac joint. They come, we put them through our test. We do the surgery that was today it was 15 minutes.
I think so.
No, it was 12 minutes, but usually it's about under 20 minutes. We do a 20-minute surgery, and then next time they come to the office, they stand up, they hug you, they literally hug you because their life has changed.
I had Dr. Abbasi had a patient one time, and she was so happy. She didn't have an appointment. She drove past our office. She actually turned around and came inside to show off to me how she can do these different dance moves pretty much.
Wow.
She was so happy. Do you remember that?
Posted the picture as well of a video of someone who was dancing, I guess. Like,
but I think he had OLIF.
Actually, I just want to say something about SIJ because just like anyone else in my part of the world, I also never bothered about this joint. I said, just learn it in anatomy, or probably they might ask you in surgery for like they are usually ask in the practical exam, okay, just perform Faber's test. So you must tell that, or spondyloarthropathies, for that purpose, about sacroiliac joint, because sacroiliitis is the chief finding in the spondyloarthropathies. But it was like 6-7 months back when Dr. Abbasi actually posted like the real pictures of sacroiliac joint, the anatomy of sacroiliac joint, and most importantly, then there was this fusion, or like the pictures of like the ones we saw today in the operation theater, the real pictures of like SIJ fusion, the trident one. And you see when you posted the real picture, like the Eller part and the interosseous part of the sacroiliac joint, I said, how can a joint look like that? That was so surreal. And then I just actually Googled the stuff, what is sacroiliac joint, then saw videos, then I just came to this podcast, and then I was following the channel already. I was seeing all the videos, so I just see SIJ trident fusion. He posted the video there, and I thought like how neglected it is, because it is as important as our spine.
Now, as a matter of fact, one of the problems with the sacroiliac joint is that it's not a real joint. See, sacroiliac joint is the part of our spine and the pelvis that connect actually spine and the pelvis. And it has only one function. In the female, when they give birth to a baby, open up the spine about 4 degrees. That's it. If it opens more than 6 degrees, pathologic no matter what. 4 degrees for the baby to pass through the birthing process. But beside that has no function. Because it has no function, nature allows lots of variation. So something that would be completely abnormal in any other joint can be normal in sacroiliac joint, vice versa. It can look fairly normal but cause significant pain because there are a lot of variability in the sacroiliac joint, contrary to other joints. Like, imagine if your hip joint was like that, you couldn't walk. But you don't have to walk with sacroiliac joint, so it can be that bad and still be not painful. But and it's one of those joints that you don't get the picture. There's not the X-ray or CAT scan and MRI that says it is. It's a truly clinical test that they prove that is the problem, mostly with multiple injection that gives you temporary relief. Now, for that reason, because it's so different from our other joint, that's the same reason that's so neglected.
Of course.
Yeah.
Sir, can you just tell like about these 4 or 5 tests like that you perform for SIJ?
Now, let's start with the sacroiliac joint. We talked about that, why, what it is. Now, generally, it's a disease of younger folk.
Yes.
People who have sacroiliac joint problem, if you're looking for that, are mostly female, but male as well. But probably it's more among female in the childbearing age. So average age of the sacroiliac joint problem compared to spine is 15, 20 years younger. And if you had the delivery, if you have given birth to a baby, for few years, your risk of having sacroiliac joint problem is tremendously higher. Obviously, trauma can cause that. Typically, this patient, they tell me that in the night when they turn from side to side, it wakes them up. Now, everybody turns in the night. Generally, every 20 minutes you turn from side to side. Otherwise, you would have sore pressures and wounds in your back.
Pressure ulcers.
Yeah. But everybody does that. But people with sacroiliac joint, every time they do that, it wakes them up. Because of the pain. So that is typical. They say, the pain is so much worse in the night. So this is what you can look for. But then you do so-called provocation test. Provocation test meaning that you put pressure on a joint to see if it's painful. Now, the problem with sacroiliac joint is that so secured, your whole weight is hanging on it. It has tremendous ligamental structure, tough membranes and bands around it to stabilize it. It's not easy to do provocation test. So what do? We use mostly the femur, that literally are big bones in the leg to aggravate the pressure on the sacroiliac joint. And those have special names like Faber, Gainslin, thigh thrust, distraction, and so on. But do me a favor. If you have any question, ask the patient stand up, turn around, and put their thumb on where the pain is. And they repeatedly put the finger on where the pain is. They say, my pain is right here. And if they twice put it within 1 inch of where the sacroiliac joint is, we have a name for that. We call that the 14 test.
And sir, one more thing, sir, like there was this dictum sort of, like you made this dictum that if you have the paravertebral pain, then that is most likely not lumbar in origin. That is most likely can be sacroiliac.
Could be. You always have to include that in your differential diagnosis. Now, you remember we said if 100 people come to you, 23 of them have sacroiliac joint.
Yes.
But what does that mean? Meaning 67% do have spine. So it has to be a differential diagnosis with clinical tools that you investigated, but include that because 1/4 of those patients will have sacroiliac joint problem.
So in India, Pakistan, scoliosis is a very, very important, very prevalent problem, scoliosis, right? Because of the socio-economic status, malnutrition, their stunted growth, right? Because adequate food cannot be provided to because the population is a lot and there is poverty and limited resources, as sir just mentioned. So how can I just had this question yesterday while I was sleeping, I had this question that I'll ask in tomorrow's podcast. So having seen a lot of scoliosis cases in my country and definitely in India as well, what are the prospects? What prospects does trans-cambial OLIF hold for those people who have scoliosis in that part of the world?
Okay, so let's start with the soft transition process. The first level of soft transition process is L1 to L5 OLIF. And level 2 is L5S1.
Yes.
And then level 3, we start with grade 1 spondylolisthesis. And the level 4 is we go on to scoliosis less than 15 degree.
Yes. Okay.
Segmental correction, meaning that 1 and 2 level max, less than 15 degree. Level 5, we go from 15 to 25 degree scoliosis and grade 2 spondylolisthesis. Once you get really good with that, then the level 6 becomes like scoliosis above 35 degree rotation of the vertebral body, meaning the rotation of the vertebral body has huge impact on the way you do this procedure.
So
because
more or less segmental correction will be done, basically.
Oh yes, but then once you get to the level 6 and 7,
Yep.
then you can do level 6 and 7
Yep.
is scoliosis of up to 60 degree.
Oh.
And but 60 degree in this CAT scan, what means that when this is CAT scan, they're laying down. When you stand up, that 60 degree can be 80 degree easily.
Yep.
But then as well, rotation up to 35 degree, which is extremely important. Those are truly heavy cases that you have to have tremendous amount of experience to do. But we are talking about people that the x-ray that usually is like here, like this in the OR, the x-ray look like this to get the true lateral picture. Those are, but we do plenty of that, and we have a platform to teach that to people. So meaning that I have done T10 to S1 fusion,
Yes.
and with quite tremendous scoliosis. And the results, once you get good at it, the results are, you can do those surgeries in 2 hours, 2.5 hours, rather than stage 2-day surgery.
So I actually asked this question because spondylolisthesis and spondylosis and spinal stenosis, like these are very, very common, like particularly old age stuff. Unless like the spondylolisthesis is not like ecthymic, like the traumatic one, right? But when it comes to scoliosis, this is prevalent more in our part of the world, in the young adults.
So juvenile scoliosis.
Juvenile scoliosis. So basically what they do is like, they don't do, obviously nobody knows about trans-cambial OLIF there. So like they go for like the
regular surgery,
and they only go for it like if it's sort of compromising the volume of thoracic cavity, and you see other abdominal structures are compromised, they do it then. But can we do it like even if it's not exerting any significant symptoms?
So in the United States, I'm not declaring that I'm a juvenile scoliosis surgeon. I'm not. Dr. Kim is. Get together with Dr. Kim, talk to him. But as a matter of fact, next week when I'm not here, maybe you guys should do with Dr. Kim a juvenile scoliosis podcast. Let's do that.
Kim would love that.
Dr. Kim will love that. Let him talk about that. But generally, we have a lot of information that at certain age, if the curvature goes over certain point, it is much better to do it preemptively than wait until it goes to a point that it becomes much harder to treat. Okay, but let's keep that for Dr. Kim since he's an expert in that. Okay. Okay.
Actually, you see, you might have experienced this, that actually the girls with scoliosis there in India and Pakistan, and particularly the girls, I don't know, like this is a sort of a taboo or like what? The parents don't bring them to the neurosurgeon or like the spine surgeon or even orthopedic surgeon just to have care. They say like it's sort of a taboo or sort of stigma just to bring them there, because probably it's they have this in their mind that since they're the spine of their child is like S-shaped, or like it's deviant from what normal population has, so that may impede her future prospects for sort of like marriage or getting job or like being liked by someone, stuff like this. So this is actually like we can actually offer them if we bring trans-cambial OLIF to that part of the world, which Dr. Abbasi has started in India, hopefully next year in Pakistan as well. So this actually taboo can also be addressed, because I've seen it for myself. Like you see people hesitating, not bringing their girls for the care.
No, lots of people with deformity, no matter what, they're stigmatized. And unfortunately, that's not that only in Pakistan. It's in the rest of the world, including United States. Everybody need to have comply with certain expectation how you look like. Sometimes it's just a tragedy, but sometimes it's just silly. Like in Iran, now Iranian women, they have bigger nose.
Bigger what?
Nose.
Okay.
Bigger nose, God gave us, but everybody loves the Caucasian European nose. So almost every single Iranian woman that I know had a nose job to just
nose job is like they cut the cartilage.
what they do, they do a rhinoplasty to make and then they break it from inside and then they reset it, so becomes
Wow.
like Amanda's
Like
nose.
Amanda, just show me.
Like Amanda's
You
nose.
see, the other day, actually, my mother was talking about this nose job, and I was like, "What are you guys talking about?" She says, "This is like the Middle East. It is very prevalent. Like,
Yeah.
this is in Lebanon, I guess.
Yeah.
Yeah, they do it.
The girls actually once they grow up, they actually get their nose cut or like what, and then I searched it on YouTube, and it was sir actually mentioned like rhinoplasty. It's
Yeah.
the procedure, and they call it nose job.
Yeah.
And one of our prime ministers, sir, you might know her, Benazir Bhutto.
Oh yeah,
So-
everyone knows Benazir Bhutto.
Benazir Bhutto. So while she was 2 times prime minister in Pakistan,
Yeah.
so she actually, while she was studying at Oxford, she had gotten a nose job.
Yeah.
And I was like amazed, like what is the prime minister doing?
Okay,
You
well,
can get anything changed.
okay, so
anything you
that is a
want.
good story for multiple reasons.
Yep.
Number one, that she had a nose job, but long before in the United States we had a female president, India and Pakistan had female head of states.
Yeah, maybe
Yes.
the US
Make-
should pay attention. to
Okay,
that.
no,
Yes.
make a note of that. Okay,
Yep, that's very important. Yep, she was 2 time prime minister. That
Yeah.
is absolutely right.
I
so
actually did one time go through like a lot of countries that had female prime ministers and also non whatever the country is, like not born there.
Yep.
The US is so behind.
Yeah.
well, we are catching up. We are
So-
catching
I hope
up.
so.
Sir, I think so. We should talk about our quiz because we have upcoming quiz for the members of the Kambin Society and anyone who can join, particularly from Pakistan, India, and anywhere in the world.
Mhm.
We'll be having short quizzes. They'll start from the next week. I just talked to Jamie,
Okay.
and we are actually designing a platform for that. So, guys, like if you ace the quizzes like with good scores, they'll be pretty easy. Like you can just do the quiz while in the bed, right?
Show off your outfits.
So yeah, so you'll be given a prize by the Kambin Society and the Inspired Spine. So
Miss Amanda, by Miss Amanda.
by the boss,
By the
Amanda.
boss.
So just stay tuned because next week we'll be launching the quizzes.
Yes.
Stay
yes.
tuned.
So and especially that we have multiple events coming up.
Yep.
One of our next event is actually our symposium, online
Before that,
symposium with Pakistan
Yep.
surgeon.
Yep.
Then on the 13th of September, we have live podcast of actual trans-cambial surgery fusion, OLIF,
Yep.
and sacroiliac joint fusion. Then on the 14th, we have our first Kambin Society meeting. We have high-level presenters. Some of them are celebrity. Go to kambinsociety.org, look at our curriculum and our presentations. And then almost a month later, we are in
1 month
India.
after that.
Yep.
We are in India within the MISSAB Conference 24 in India. We have 1.5 hour just dedicated Kambin Society meeting.
Yes.
And then hopefully this is a wildfire that's going to catch up with the rest of the region and hopefully eventually come back to United States
Yes.
and infect our own surgeons here who has
Yeah.
been pretty resistant
Yeah.
to learn new things, but
Yeah.
it's catching up here as well. So we are very hopeful, but so stay in touch, stay connected, stay tuned.
Nobody wants to be the last one to learn OLIF, right?
That's right.
Yeah.
That's right.
Don't miss the bus, guys.
Yeah.
This is very important. This is the future. So
Thank you guys for watching. This was Essence of Medicine. Today we talked about
Multiple
a lot of
a
things.
lot of things starting from the USMLEs.
It was perfect. I'm Amanda Armagast.
I'm Dr. Abbasi and our guest.
I'm Mohammad Daman Bashir.
Thank
Thank you for joining us.